Hello guys, my name is Della and today we are going to talk about the ventilator modes or about mechanical ventilations. So we have our objectives. We are going to talk about what is volume control, pressure support, CPAP or continuous positive airway pressure, and its functions and some examples of the modes for the volume and pressure control. And we are also going to differentiate the between volume and pressure control. And we are going to discuss some differences between the pressure and the volume waveforms. And we're going to also tackle about our initial settings for all of the modes, just in general, a general initial setting. And then we're also going to discuss lung protective ventilation or how to put or do an initial setting for a lung protecting. And then lastly, we are going to discuss the mode for weaning or how the weaning is being done. So what is volume control? Let's start there. So it says here on our PowerPoint that in volume control, we set a tidal volume that is delivered at a set rate. That is true because in volume control, we set a tidal volume and the pressure that is being given to the patient will vary depending on the patient's need, but the volume is going to be set, like whatever happens to the patient's breathing or whatever happens to the lung mechanics of the lung mechanics, the volume is going to be the same every breath. So this is primarily used for patients that can't spontaneously breathe, or patient that is actually like sedated, and but that doesn't mean that we can't use this for patients that can spontaneously breathe. So it's just basically saying here that it's primarily, or we use this more often to patients that's actually sedated or can't spontaneously breathe. Volume is set, as we said earlier, and the pressure will vary between breaths. That means that our peak pressure or our peak inspiratory pressure or our PIP will vary between breath to breath, and that will depend on the patient's lung compliance and resistance. So if the patient's compliance is low and the resistance increases, that means we are going into more of a restrictive pattern. So there's going to be like a stiff lung. That means our PIP will increase because we're just giving more volume because it's getting stiffer. So we're getting more volume in there while the pressure is trying to gradually increase. That means that the PIP will increase, or the pressure that we get and our inspiration, because we're just giving that volume. That's how much volume. So some volume controlled modes that is available for this mode for volume control are assist controlled ventilation or ACV, or synchronized intermittent mandatory ventilation or SIMV. So I'm going to focus more on the assist control, and I'm not going to talk anything about SIMV at this point. That's for another lecture. So just to like a touch up for this one, if let's say we we set a pressure, I mean a volume of 4,500 mLs at a rate of let's say 20, because in here it says that the volume control, we set a tidal volume that is delivered at a set rate. So we set a tidal volume and we set a rate. So let's say that we set 4,500 mLs for tidal volume and let's say 20 breaths per minute for respiratory rate or R rate. So that means that the 4,500 tidal volume will be divided into 20. So that means that And 4500, the 4500 will be delivered in per breath in 20s. So the way we're going to determine how much volume the patient is getting per breath is we could divide the 4500 with 20, and that will be around 225 mLs. So that means in every breath that the patient takes in 20 breaths per minute, the patient will get 225 mLs per breath. So that's if we kind of think of it, that's like an actually like kind of good for the patient, because every breath the patient has actually getting a good volume that the patient's body will be needing. So that's good for that. Let's go over assist control ventilation. So again, this is a mode from that is in a volume. So this mode is volume based. So this was previously known as CMV, or continuous mandatory ventilation, before. And then so as we said earlier, each breath in here will be um, will be either assisted or controlled. So it can be assisted, it can be controlled, because as you said, as it states, it's assist control. So there's an assist in here if the patient is spontaneously breathing. So the ventilator could just assist. But if the patient all of a sudden, gets knocked out by a sedation, then it could be switched into a controlled breath. So that being said, all of those breaths will have the same volume. So every breath will have, let's say, 225 mLs, as an example. So that will not vary. It's going to be constant. It's a volume guarantee in a sense. And then, so that being said, if we're giving larger volumes, we need to have more expiratory time. Now, why is that? We need more expiratory time because we're giving larger volumes. If we give larger volumes, that means that a lot of the volume could remain or be retained in the lungs. That's why we need more expiratory time. That way, we know that whatever goes in could potentially come out. So, because if we don't do that, as it says in here, it could induce hyperinflation and respiratory alkalosis because we have too much oxygen inside. So we are trying to prevent having lung injuries, or in this case, hyperinflation. So we need to set more expiratory time rather inspiratory. So this is also very ideal for patients that's having some neurological diseases that will cause muscle weakness. So like myasthenia gravis, or some other diseases that could potentially induce some muscle weakness. Now, why is that? That's like a good question every time that we could ask yourself. Why is volume control good for patients with muscle weakness? It's good because we're giving a set volume that the patient will be, that the patient's body is demanding. So patients with muscle weakness, they can trigger spontaneous breaths. So this is good for them because we are giving them an actual set volume. So there's more gas exchange that could happen in there. So that's basically what volume control is. Just like a vague touch up on what it is. So now let's move on to pressure control mode. So what is pressure control mode? So it's kind of like a vice versa for volume control. In this case, we are setting a pressure and the volume will be variable. So this mode of ventilation, it'll be delivering breaths at a set pressure with a set rate. So that's kind of like the similarities of volume and pressure is that they both set a rate with the um, pressure or volume that's being set. So the rate is kind of constant for both. So this mode again, one of the similarities is that this mode is also for patients that is sedated or patients that can't spontaneously breathe. Excuse me, but that doesn't mean also that it's only for patients that sedated or can spontaneously breathe. This can also be good for patients that can spontaneously breathe or awake. So this helps with oxygenating by keeping alveoli slightly open. Now, how does the pressure control do that? It does it by so when we put pressure and pressure control, it's more like a square form for the waveform, and I'll show it to you guys later, and I will elaborate it more in there. So in a square form, it's basically shooting up into the set pressure and staying there for like a constant, that constant pressure for a couple of seconds before it exhales. So what it does on the exhalation is it applies another pressure which is called PEEP, or positive end expiratory pressure. So let's say we put the PEEP at 4 or 5. Let's say 5 because 5 is a normal PEEP level. So if we put that PEEP in there, when the pressure ends and go into exhalation, the PEEP of 5 will stay on the lungs or the alveoli and will keep it slightly open. So that means that it will also decrease the chances of patients having atelectasis because it's keeping the alveoli slightly open. It will also improve, as I said, the oxygenation. Why? Because we are keeping them open, and so when the tidal volume comes in there, or the volume of gas goes in there, there's more gas exchange that could happen because they are maintained as open. And consolidation will be reduced as well because again it's open, so when alveoli are open, they usually kick out fluids in a normal lung. So that's how it's increasing or helping with the oxygenation. Now, in this control mode, we can also set the I time, and then of course the respiratory rate, and then the pressure. So I time can be controlled in this part. So let's see, inspiration is held at a set pressure. We've talked about that. Spontaneous triggered breaths are delivered with the same settings. Okay, so when the patient is sedated and they're getting this settings, like let's say pressure of 20, respiratory rate of 15, I time of 1, and PEEP of 5. Let's say those are all the patient setting right now while she's sedated or he's sedated. Now, when the patient is awake and all of a sudden started spontaneously breathing, all of those settings will carry over once the patient is awake. So that doesn't. So let's say when the patient is sedated and awake, all of those settings are not gonna change. There's no changes that's gonna happen. So everything is going to be kept. So that's what it's saying in there. Now, if let's say the patient is desynchronizing with the vent, we could mess up or kind of play with the I time or our respiratory rate or our pressure to kind of help the patient go kind of pull back towards synchronizing with the vent. Now, if they still desynchronize or bucking the vent, we could switch to a volume control to try and see if the patient will tolerate it better. So the way the ventilator works, or the mechanical ventilator works, is we try. It's like a trial and error. It's like everything in this world. It's like a trial and error. If one doesn't work, then we could switch with the other. So that's why they created a lot of modes, is to help with the patient's comfort and synchronizing with the vent. That way, we could assure that we are not creating any lung injuries or making them worse as we speak, or trying to, as much as possible, trying to keep them out of staying in the ventilator. Okay. Sorry about the intermission. So some examples in this one is we have pressure controlled ventilation or PCV, pressure support ventilation or PSV, or pressure controlled inverse ratio ventilation or PCIRV, or APRV, which stands for airway pressure release ventilation. So at this point, I'm going to talk about APRV and just focus solely closely in there. So APRV. So patients are able to spontaneously breathe at both low and high pressures, and they can spend majority of its time at the higher inspiratory pressure. So I'm not going to go over all of this information in here, but basically what APRV is it's more of a variety of CPAP. So there's like different kinds of like CPAP pressure that it could give. So there's like a variation of it. And then towards the exhalation, because it's still a pressure control mode, it will give that certain pressure during inhalation. But this will terminate the pressure when it goes to exhalation to make sure that, that we are not creating volume trauma or trauma by volume. So that being said, this mode of ventilation is more on the higher side. Okay, so I'm going to continue explaining this on the next video. Thank you for watching.